I want to go back to the moment the doctor offered me pain relief. Because I glossed over something in episode 1 that deserves its own examination, I hesitated. I was in severe pain. I had a confirmed diagnosis. The physician in front of me was competent, empathetic, and doing his job well. There was no clinical reason to hesitate, and I hesitated anyway, not because of the medication, because of who I am and because of what I have seen. I am a black man. I spent 20 years as a physician, and in those 20 years I watched, in real time, how black patients in pain are sometimes treated. The raised eyebrow before the chart review, the recalibration of how much pain a black body is assumed to be capable of feeling or performing, the mythology, and I use that word deliberately, that black patients have a higher pain tolerance, that their reported pain is less credible, that they are more likely seeking drugs than relief. I had seen that mythology in action. I had watched senior physicians apply it to patients in front of me. I had never said enough about it in the moments when I should have. And then I walked into an emergency room at 4 a.m. as the patient, and I applied it to myself. My knowledge of the bias did not protect me from internalizing it. It made me enforce it on myself. After the morphine, after I came back and told the doctor it hadn't worked, he offered a second dose, a different medication. He was being thorough. He was being kind. I said no, that's what I told him. I told him, to be honest, the shot knocked me out, but the pain was still bad. I can wait until they do the surgery. The pain will be gone when I wake up. That was not bravery. I want to be clear about that. I was not being stoic. I was performing. I was performing for a doctor who had shown me no reason to distrust him. I was performing so that he would not, in some hypothetical paranoid corner of my mind, think I was a drug seeker. I was protecting the reputation of black people in a room where only I knew I was doing it. That is a real thing. That is a psychological burden that falls on members of marginalized groups in spaces where they know stereotypes exist. You become hyper-aware of how your behavior will be read through the lens of the mythology, and you modify that behavior not to protect yourself, but to protect the group you belong to, even when it costs you, even when it hurts you. I want to tell you about a post I read recently. In a chronic pain group I belong to, someone shared data about women, specifically about how women's pain is treated in clinical settings. Women receive less pain medication than men for equivalent reported pain. Their pain is more often attributed to anxiety, to depression, to emotional causes rather than physical ones. They are more likely to be told that what they are experiencing is not what they think it is. Black women sit at the intersection of both of those disparities. The racial bias in pain management and the gender bias in pain management do not simply add together. They compound. The data on this is not new. It is not contested. And it is not subtle. I am a retired physician with 20 years of experience in pain management. I understood my own symptoms. I understood the pharmacology of what I was being offered. I had every tool available to advocate for myself, and I still sat in that room doing a calculation about how my accepting pain relief would be perceived. Now imagine doing that without the medical training. Imagine being a black woman in that room, or in a chronic pain appointment, or in a labor and delivery ward, with the same internalized awareness that your pain may not be taken seriously, and having to decide in real time whether to advocate loudly for yourself and risk being labeled difficult, or to stay quiet and risk being undertreated. That is not a hypothetical. That is the daily calculation of millions of patients. I am not offering you a clean resolution. There isn't one. The bias in pain management is structural. It is persistent. It is not solved by a single conversation or a single video. But there are things worth saying directly. To patients, you are entitled to adequate pain management. You are entitled to ask your physician to explain their reasoning. You are not obligated to absorb undertreatment silently to protect anyone's comfort, not even to protect the comfort of a system that has not yet earned your trust. To providers, the mythology about pain tolerance in black patients was traced back to discredited 19th century pseudoscience. It has no basis in biology. It has no place in a clinical encounter. And the reflexive attribution of women's physical pain to emotional causes is not medicine. It is a pattern. And patterns can be examined and broken. And to everyone watching this, the fact that I, a retired doctor who knew exactly what was happening in his own body, still hesitated to accept pain relief because of how he feared being perceived. That tells you something, not about me, about the weight of this mythology, about how it lives not just in the clinicians who hold it, but in the patients who walk in already braced for it. My appendix was removed that morning. The procedure was uneventful. I recovered. I moved. And I have thought about that night almost every day since. Not because of the surgery, because of what I did to myself before they wheeled me in, and because I wonder how many people in how many rooms are doing the same thing right now. If this is your story, if you have ever modified how you present your pain because of who you are and what you know about the room, I want you to know I see it. And I want you to know that the weight you are carrying was never supposed to be yours. Learn more about these stories and systemic challenges in healthcare on youandbedsidemanners.com. Like and share this video if you have ever been that patient in that room.